Thank you. It's a pleasure to be here and to introduce our lovely panel. It's a great topic because I think as those of us at Harvard here, it's an academic institution, and we want to learn from the lessons of the HIV response. So I'd just like to make a few comments. About 30 or 40 years ago, when I was a graduate student in virology, I went to Senegal for the first time, my first trip to Africa with Max Essex, and I met an assistant professor of virology, Dr. Suleiman Boop. And we, at that first meeting, we signed an inter-university agreement that would dictate how we would do research on HIV for the long-term future. And I'm very proud that we actually held to that agreement, and we trained lots of Senegalese physicians and healthcare workers and laboratory scientists, and we conducted very productive research on HIV-2, which was the West African virus. And so I think that became an important model for co-equal partnership, which I think is very important if we think about the importance of research for all health problems in the future to come. And the other point I wanted to make was about PEPFAR. I was fortunate enough to direct the first PEPFAR program here at Harvard. It was a 3-country program in Tanzania, Botswana, and Nigeria. And as many of you know, this is the 20th year anniversary. It was a unique and really groundbreaking program, saving 25 million lives and more to come. But I think importantly was really founded on the principle of country ownership. And although at the very beginning in 2004, they were still sort of figuring out how all of that would work, I think over the years they've gotten that to be better. They've understood the importance of community involvement all the way down to the grassroots, and they've understood what co-equal engagement means for sustainability. So I hope we can think about those lessons as we move forward. So I have the pleasure of introducing our panel today. Professor Linda Gale Becker is a professor of medicine at the Desmond Tutu HIV Center and at the University of Cape Town, and she's the CEO of the Desmond Tutu Health Foundation. So thank you for joining us. We have Maureen Luba, who I've known for many, many years. She's a program manager in Malawi at Cooper Smith, and I understand is a degree candidate again back here at Harvard. Dr. Mozapeli, who's from the University of Botswana. I've also had the pleasure of working at least alongside many of our colleagues from Botswana, and we're very happy he made the long trip to come here. And then my dear friend and colleague, Dr. Shaheen Lockman, who's an associate professor both at my school, at the School of Public Health, but also at the Brigham, and who has been involved with the Botswana-Harvard partnership since its beginning. So thank you very much.
Thank you all for being here today in person and online, and thank you so much for convening this particular panel, which we're very excited about. So I think it's known to all that over the past 3 decades, the global community has collaborated on a massive expansion of HIV diagnosis, care, treatment, and prevention programs, scientific and research capacity, and investigation, and community engagement around HIV. Much clearly remains to be done. We are not finished with that work, and not all communities, not all people have benefited equally from the investments made. Nevertheless, it is fair to say that we have succeeded in many ways. 3/4 of people living with HIV now are estimated to be on potent treatment for HIV. The rate of HIV and AIDS-related deaths has dropped by more than 70% since the peak of AIDS-related deaths, and new HIV infections have also been reduced by more than half since 1996. So our panelists here in person and online, each in their own particular areas of expertise, have a total of more than 50 years of experience tackling HIV. Just think about that, 50 years. And so really, I think today we want to ask these esteemed individuals with their cumulative wisdom and experience to reflect on what we've learned from this decades-long local, regional, and global partnerships that were established to combat HIV. I think we'd like to hear about partnerships that have successfully included affected communities over time, and what impact community involvement has had on equitable HIV care. And perhaps at least as importantly, hopefully we can have some candid conversation and remarks about instances in which that didn't happen and the downsides of lack of community engagement. I'm hoping we can also explore how these HIV-focused partnerships may already be addressing other public health issues. And looking forward, reflect on the guiding principles, particularly equity and community engagement, that our partnerships need to follow as we tackle ongoing and future health challenges. I think we're going to have a round of questions going really from Maureen to Mosapele to Linda Gale, initially talking a little bit about community and partnerships, and then really folding in equity. These are obviously overlapping and interwoven, but for each of you, I'm also hoping that you will be able to address the particular, when you think about and engage community and think about partnerships, what those specific communities and partnerships are, because you each bring very different perspectives, again, overlapping, but quite different. So first, I'm also hoping that each of you can maybe tell us why and how did you get here today? A little bit about your journey on your path, Maureen, starting with you, your journey to advocacy and activism, and how you were, and why you're here today.
Thank you so much, Shaheen. So I wear so many hats, but I think one of the hats that I hold so dear to my heart is that of being a community representative. I think I would say, if I may, of course, borrow from a leaf from Winnie, I would like to share a personal story, because my journey, my advocacy journey has been quite emotional. I remember back in 2013, fresh from college, I was excited about life. I was excited about, advancing my career. And my first job was with, back in Malawi then, I was with National Association for People Living with HIV. So I used to spend most of my time, working in the communities, working with people living with HIV, most of them vulnerable, poor, women, and all that. And it was, I still remember, it was in December, one early morning, I was just out in the field doing my routine meetings, but with this time around, I was meeting a support group of people women living with HIV. It was a small group, and I noticed that among the group was this woman who looked older. My guess was she was maybe late 60s, 70s, early 70s. But I had so many questions, because by then I was still, young, so naive about HIV. I was still learning a lot about HIV. So I had so many questions. How come she's part of the group? How did she get infected? Because my understanding was that HIV was only for sexually active, young, sexually active people. So I had so many questions. But I noticed something else during the course of the meeting, that she was shivering, she was shaking shaking throughout the meeting, and I was quite disturbed. So immediately after the meeting, I reached out to her. I wanted to understand how she was doing, and that's when she told me. I asked her why she was, shaking throughout the meeting. That's when she told me the reason why she was shaking. It was the effect of the medication that she took. Every time she took the medication on an empty stomach, it would actually make her shiver. That's when I realized that she had taken her medication and she didn't eat anything. So I also noticed that her clothes were soiled, and when I asked her where she was coming, she told me she was coming from a garden. So apparently she had borrowed a small basin of maize from one of her neighbors, and in return, she was asked to dig in the garden about 1 acre. I felt so sad. I wanted to learn more about her story, so we offered a lift, back home. We offered her a lift back home, and that's when she told me how she got infected. Apparently, her husband back then he used to work as a night watchman in a nearby township. He used to sleep around with women. She knew about this. Every time she would confront him, he would threaten to kick her out. She had nowhere to go, so she had to stay in the marriage. Apparently she got infected. But she also taught me something else, that also disturbed me. She was like, every month she had to travel a distance of 10 kilometers on foot to get her medication. And I asked myself, can a woman like her even have a chance to meet, policymakers, funders, and decision makers to just share her problem for them to understand what she really needs? So that's when I made a commitment that I'll do what I can. I'll use, the platform, my voice, any platform, to raise the voice of communities, to raise the voice of women like her. So it's been tough. It's challenging. There are times when you're frustrated, you think you're not making headways, but every time I feel like giving up, a voice keeps telling me, Maureen, you're not giving up. You're not letting those women down. So that's how I've kind of found myself here.
Thank you so much. And that story, that one story, so beautifully illustrates the many impediments and challenges that individuals living with HIV face every single day. And so I think you've worked in many capacities in advocacy and activism, too numerous to expound on in detail, but can you give an example or two of particular instances or experiences during that advocacy and activism in which you could see the effective inclusion of community voices and how that improved outcomes, or conversely, how the lack of that inclusion and true inclusiveness led to poor outcomes?
Yeah, I think I just wanted, to start by emphasizing that when we talk about community engagement, it has to be at all levels. I think it's great to see that now there's great recognition for community leadership, community participation, community engagement. But sometimes we tend to pick and choose, right? Sometimes we say we only want to engage community. Okay, now there's, this whole idea of, for example, putting together community advisory boards, right? Which is great, but there are times when you pick to choose and say, oh, we can't involve communities at this level. This is too technical for them to understand. No, make them understand, because at that moment when we start to pick and choose, that's where we start making, mistakes, right? That's when we start leaving communities out. I think I would say there are a lot of examples, in which community have been, participation has been vibrant and effective. And I think one that quickly comes to mind for me, I always think about, the DDG transition. Mm-hmm. If you remember back in 2018, preliminary results from an independent study that was conducted in Botswana then had identified a potential safety issue with DDG. Actually, 4 out of 426 women who got pregnant was on DDG had tube defects. I remember that caused a great deal of panic, because by then DDG, was being considered as a game changer for people living HIV because of its, great tolerance, high potency, but also high resistance barrier. And countries had to make decisions, right? So there was a great deal of panic among communities, but also among, policymakers, Minister of Health. I remember that's when I saw how communities, especially women living with HIV, were involved, right, in the conversation. There were a lot of consultations that were organized by WHO. I remember women were involved, not just at country level, but also at the regional level, but also at the global level, in making those decisions. Because I think at that time, WHO realized that it was really important, to make sure that communication was very transparent and also consistent. Because by then we had already started hearing myths, to say, oh, ARVs will make you, infertile, things like those. So you had to make sure that communities had access to information. They were being represented at different forums and distilling that same information to communities on the ground, so that, the demand for ARVs, the demand for access to medication was still there. So I think for me, that's like a great example. And because of that great community engagement, we were able to resolve that issue. And I think another one, which is more recently, which I think is quite inspiring, is how I've seen this issue of community-led monitoring. You hear a lot about it in the HIV space. It's becoming a thing now, whereby communities are being empowered, right, to take leadership in monitoring how services are being delivered, the quality of the services. So what they do, thanks to Global Fund and PERFA, by the way, they're providing support to communities so that they can do this community-led monitoring. So communities go into the facilities, they go into the communities, they talk to recipients of care, they talk to healthcare workers, and then try to understand where are the challenges, where are we missing it, and then they use those findings now to engage policymakers, healthcare workers, donors, to say this is how we're supposed to address the existing challenges. So it's a great example in which communities are actively involved, yes, in identifying the challenges, but also providing solutions and being engaged at different levels where decisions are being made. I don't know if I still have time, but I mean another great example that I would like to share is a project that is being implemented in Malawi. It's called Blantyre Prevention Strategy. It's also a great example when you think about bringing all hands on deck. So how Blantyre Prevention Strategy works is that it has brought together, the goal is to reduce new HIV infections in Blantyre, but it has actually brought together communities, healthcare workers, district planners, policymakers to identify. So there's a platform called PAMS that draws data sets from that uses information from different data sets to draw some insights in terms of what's happening with HIV prevention in Blantyre. Where are we seeing new HIV infections? So communities, how they are involved is they are involved in the production of that knowledge, but also they are the users of that information. So those are some of the examples that I can say I've seen great, partnerships where communities have been fully involved. Of course, there are also other bad ones where, we haven't seen that great deal of community participation. The results are pretty bad.
Thank you so much. Those are remarkable examples. And I can say, reflecting from the perspective of just the global perspective, each of those examples I am aware has informed policy, it intersects also the first one with reproductive health. So the results are tangible when done, when true engagement happens and people are empowered. Thank you so much, Maureen. So now I'm just going to turn now to you, Mosapele. And would you mind also describing your journey? What led to you being here today, and why? Why did you choose this journey? And how has it led to some unexpected twists and turns, particularly during COVID?
Thank you very much, Shaheen, and good afternoon, everyone in Boston and those who are far away. Good morning, good evening. Depending on where you are. I have been very, very fortunate, Shaheen, in that I grew up in a country that's very peaceful, and education was free. Never had to pay a dime for my education. And therefore, also where there is immense potential for growth and opportunities. Country the size of Texas with 2.3 million people. Imagine what if you were maybe one of the first infectious disease doctors, what you could do. So I've been very fortunate to get to that. And whilst I was settling in to develop a career in infectious diseases in Botswana, COVID-19 happened. I never saw that coming my way. Was very fortunate when that happened. Literally, I had flown to the US for CROI. I spent a weekend in a hotel here in Boston and had to fly back because CROI was not happening. And on the Monday when I landed, we were summoned to an office and told we have to form a COVID task force. And I was like, oh Lord, okay. I thought I was still remain in the medical school and just give advice, but I found myself deputizing the presidential COVID-19 task force and chief negotiator for the COVID-19 vaccine. So it was an interesting experience.
Thank you. Interesting is one word for it. I'm sure it's incredibly grueling and challenging, but highly impactful. I think maybe could you describe a little bit the partnerships that you had to engage? I guess now, since we're given the topic that we have at hand, the existing expertise, infrastructure, and longstanding partnerships in Botswana that had been established to respond to HIV, how you engaged these partners to swiftly respond to COVID. And I think, as you maybe reflect on this, in what ways these partnerships really served the country, whether they, particularly the global partnerships, but also the within country and regional partnerships, and how they didn't maybe serve the country, and how we can make them more useful and equitable in the future.
Thank you very much, Shaheen. I'll take it back before HIV. Botswana is largely a farming community. Almost every family has cattle or goats. So we have learned a lot about disease outbreaks from when we had foot and mouth outbreaks, and they still happen because we have lots of wild animals that intermittently mix with our own cattle. And then I remember as a child also when we had contagious bovine pleuropneumonia outbreak, CBPP. And so historically, the country is divided into zones for animal disease management. Historically, we have used veterinarians to help us manage both human and animal disease. So interestingly, even for HIV, even when Phyllis, Max came to Botswana, one of the key leaders that participated in shaping the nation's response were veterinarians, the likes of Dr. Masup. So when COVID happened, we just went back to that and said, for instance, the gentleman I was deputizing was in retirement, a vet. So he came and provided leadership. And I don't know people in the animal agriculture side of things in Botswana, so he was very useful, even as we were drawing up maps for COVID-19 containment in the country. And it kind of made sense because if most people are farmers and they know how the country is demarcated and they know how movement can be restricted and they know how to move from one zone to the other where the main points of entry are, then when you start to shape a response that speaks to something they're familiar with, it sort of made a lot of sense. So, in terms of community engagement, when we started shaping the COVID-19 response, we looked up to people who had done a lot of HIV work in Botswana. And we look across board. We didn't look only at people who were doing bench work. We looked at people who were analysts, whether they are epidemiologists. But for us to truly come up with a response that engaged the community, you should just I don't know if it's available online, look at the formation of the Botswana Presidential COVID-19 Task Force. Although it was led by the president, and we met maybe twice weekly, with the president, the vice president, majority of cabinet, chiefs, business leaders, members of the community, members of the different religious denominations. I think there were a little over 100 people who met almost twice a week. And the whole idea was we could not form an appropriate, acceptable response that did not speak to the values, the expectations, the history of the people we were putting a response for. And beyond that formation, we had to travel. Despite there being COVID, whatever mode of transport we had, we went to all parts of the country. Why? To meet with the community, to meet with the leaders, and take account for what we are describing to them and asking them to do, and hear from them what their concerns were so that we could shape a response that was acceptable to them. I believe we virtually met with all regional district councils to explain to them and answer their questions. I think we met with Parliament, we met with the House of Chiefs on multiple occasions to explain to leaders in the community what it is we were doing. So it was very, very critical in Botswana to do that. We engaged everyone by putting together an amazing crisis communications team. And because it was the first time in the era of social media that we had a disease outbreak, we needed people who understood and could track, follow sentiments, and let us know what it is. You know, I remember there were times when I'd come in excited because there was a new variant that had just been discovered, and I wanted to go and talk about it. And the comms team would sit me down and say, well, that's not where the nation is today. Today, people are talking about XYZ. That's what you need to go and address. And that really, really, in a big way, contributed to a response that was responsive to what the people wanted. I remember that in certain instances, we had to even unpack our different audiences. When we went on national TV twice a week, we also plugged on and streamed live on Facebook for the young people. We plugged onto national radio for people in rural communities who could only hear us or know what was happening by listening to the radio. So we knew who we had to talk to. I don't recall a single national address that we did in English. If we had a PowerPoint presentation, it would be in English with all the fancy graphs and everything, but the spoken, the delivery would be in the local language. So there's so many things that we had to think about to make sure that the response was appropriate.
Thank you. And this clearly, this, again, multi-sectoral, laborious, sustained engagement across all sectors, and particularly with communities affected, led to what was very apparent to me, a much higher level of trust in government, trust in the guidance that you're receiving, and hence very high uptake of vaccines once they were available, use of masks, and overall compliance with the public health guidance. So congratulations to you and to Botswana on that. Thank you very much. And we'll be coming back momentarily to you, but Linda Gale, how are you?
Good. Thank you, Shaheen.
Okay, so maybe you can similarly reflect a little bit on how you ended up being where you are and why, and also then move into discussing the importance, as you see it, of civil society and community partnerships in the HIV response in South Africa, and in particular as it relates to HIV prevention in adolescent girls and young women.
Thanks, Shaheen, and a real pleasure to be part of this terrific panel. Greetings to all. And I'm aware that I probably contribute a good number of those 5 decades you were talking about earlier, but it's a real pleasure to be here. So it does take me back right to the very beginning of when our epidemic took off. I born and raised in Zimbabwe, actually, but did my medical training in South Africa and went off very happily to become a geriatrician in a very rural part of northern KwaZulu-Natal. And of course, that was just when the AIDS epidemic was truly breaking. And it was becoming apparent that South Africa would bear a very large burden of the Southern African HIV epidemic. And right there, it was clear to me as I realized that everything I'd learned at medical school was not preparing me for the incredible onslaught of a new infectious disease epidemic, that I changed course and went back to medical school to become an infectious diseases doctor and pay a lot of attention to HIV and TB, which has been my journey for the last coming on for 25, 30 years now. So it's been humbling on so many levels, because I think there are so many firsts with the HIV epidemic, and perhaps most notable is the very absence of what Mosapeli has just been describing. Leadership from government was so absent in the early parts of the South African epidemic. And it was extraordinary to my mind. And as I look back, I'm still amazed at how civil society filled that void. And moved in a way, and when he used the terminology a movement earlier in the previous session, and truly I think we saw the enactment of a movement in the country that I have never seen in any field of medicine or subsequently to the same extent. And so that really, I think, showed me just the power of civil society and community. And I think such an important lesson that how it can be an incredible force for the good, and if left out, how we lose out on exploiting a very important ingredient in our public health response. So being a clinician, a treater, as well as a preventer and a researcher, I think that was, I was so lucky, I think, if there's any luck in the HIV epidemic or any silver cloud, I was so lucky to from the very first beginnings to understand the importance of community. And I know, Partners Health and other incredible organizations in the HIV movement have also exploited that incredible ingredient of the power of community. So I think from there, we saw activism following into advocacy that led to access, that led to literacy, that reaching every single sort of corner of South Africa with this new element of antiretroviral treatment and the power and the life-changing impact of that. That was able to really, in almost a political movement, and if Treatment Action Campaign has to be, really revered in this regard, that they treated it like a political movement. We had just come out of the extraordinary time of apartheid, where political movements had reached into all kinds of corners of South Africa. Similarly, they used that same kind of cadre deployment strategy, and was able to reach really every part of South Africa, because, of course, HIV had ravaged the whole of South Africa and continues to do so. And it was through that we now, have, even in the face of a complete lack of government support, almost 5.5–6 million people now on antiretroviral treatment, that I don't believe could have been done without the basis of that civil society movement and strength. And Shaheen, I know close to your heart was the vertical transmission sort of movement where women voted with their feet. And I still remember the campaign of save a life for the cost of a single T-shirt, if you remember. So a nevirapine pill cost, something that a very cheap T-shirt would cost. And this is what we really promulgated to try and get to reach as many pregnant women to really prevent vertical transmission. So those are the days. And I think out of that was born task shifting, task sharing, and this real recognition that community can be an equal partner in the service delivery that we have to do. And every day, I really hope that HIV will become the poster child, the playbook for diseases and for epidemics in the future, because I think this is really what has led to us being at a place now where we start to see life expectancy turning, where we do see people on treatment, where we do see U equals U in a way that we can now gain secondary benefit from antiretroviral rollout and begin to look at primary prevention too. So, I unashamedly, I think the HIV success has been on the back of extraordinary community engagement, in community involvement, and importantly, community leadership. So
Thank you, Linda Gale. That was a really remarkable and powerful testimony and over to a really remarkable period in time. And this brings me to actually back to Maureen. This is a point that you had made. I actually want to turn now to focus a little more on equity and inequity, and also maybe what we here in the US and the global north can learn from our partners in Africa and elsewhere. I think we have a tremendous amount. We've already learned a lot, and we need to take that to heart, and much more to learn. And you had, in a separate conversation, mentioned the power and importance of community participation in service delivery, not as service recipients, but as people who can participate in solving the problems. And I was hoping you could reflect a little bit about that. And then also, I'm just gonna make this a two-part question, maybe talk as well about access to diagnostics and medications, which we know is painfully inequitable globally, and what you have seen, what you have seen in terms of lessons that we've learned from HIV activism with regard to increasing access to life-saving HIV treatments, and your, in your current role with the medicines patent pool, what that might mean for other conditions.
Yeah, thank you so much. I think it's important, since we are talking about, advancing equitable partnership. I think it's important to acknowledge that when you talk about, advancing equitable partnership, it goes beyond just, providing fair opportunities for partners to collaborate. It's about being intentional in acknowledging, the underlying inequalities that do exist, so that the partners that we are bringing to the table can fully participate, but also reap the benefits from those collaborations. As Linda Gelbecker is saying, are we equal partners? When we bring everyone else on the table, are we coming as equal partners? And what I mean by that is that, and this is also something that we've learned from the HIV field, when programs, programs are being designed, research is being, whether it's research concepts being designed, it's always important to make sure that they are effectively addressing the local challenges. I think we heard from Dr. Auma this morning about, listen to the priorities of the African countries, and the same applies to communities. Listen to the priorities of the communities. When you involve communities, in the design, in the planning, they bring variable insights in terms of what works and what does not work, We've seen how communities have actually provided variable, feedback on, for example, delivery mechanisms. What works for them? Do they want to access services at the facility? Do they want to access services at the community? They have also brought valuable insights in terms of effective approaches that work to addressing the existing challenges that do exist. I think in my 13 years of HIV work, I've had the opportunity of engaging different stakeholders, health care workers, regulatory bodies, policy makers, funders, and what I've noticed is that, sometimes all these stakeholders may share an overarching goal, let's say reducing new HIV infections. But when you look at their priorities, and approaches to achieving that, they differ significantly, And I'll give you an example of what is happening. Allow me to, for example, with the dapivirine link, which is an HIV prevention tool, that was, produced. Women participated in the studies. It works, And what we are hearing from women is that women want, that the ring. But then when you talk to funders, when you talk to policymakers, you kind of hear different stories. And part of the reason why there always this misalignment, in priorities, is because of that lack of collaborative planning, consultation with all different stakeholders. But when you bring all the stakeholders to the table, plan together, implement together, the results have always been remarkable, I think for me, also just going back to the question that you asked about, what has been the role of activism, for example, in increasing access to affordable medicine or ARVs. I think there's a history to that. We know that back then, I think early in the 90s, when Africa was bearing the huge burden of the HIV, when drugs were not available, they were first available in the developed countries, right? Super expensive, the monopoly that, Winnie talked about, pharmaceutical companies, they were holding the patents. The drug was ridiculously expensive, but it took a lot of community activism, right? Pushing back, court orders, right? To fight back those, patents, those monopoly. Of course, it took years, but eventually we had access, right, to life-saving medication on the continent, which is why I think for me, I'm glad, I'm so excited to be part of the community advisory panel at the Medicines Patent Pool. And I like that in their strategy, one of their goals is, to increase innovation, but also build capacity. They talk about building capacity, local capacity, manufacturing capacity, and I think we've heard a lot about that from Dr. Ouma, from Winnie also. She mentioned that, and I think I liked when Dr. Ouma said when an outbreak is small, it doesn't usually attract the attention that it requires. For example, it's interesting to hear that we still don't have, like, for example, medication for mental health, right? So Medicines Patent Pool, in their strategy, they want to, at least promote, initiate or motivate that innovation, so that we can also, pharmaceutical companies can also start investing, in the discovery of those great diseases, right? Talk about, local capacity within the African continent. Their plan is actually to make sure that they are also supporting efforts to build that local capacity. And I think as a community representative, being part of that, advisory panel, I feel like I take that as an opportunity to continue raising the voice of those women, the ones that keep pushing me, don't give up, keep pushing, right? To bring to the table the voices of the women to say, we can't repeat the history of how we fought for the access to HIV medication, right? We have to make sure that we are doing the right things. I would like to take the opportunity of being part of that panel to influence how patents are being negotiated. So for me, it's a great opportunity to bring the voices of the community into that conversation, so that communities, regardless of where you were born, where you are, everyone has access to to the medication that they need to address their challenges.
Thank you very much. And I think it's impossible to overstate the impact of HIV activism and advocacy in terms of access and where that has brought our global community in with regard to treating HIV. I will say that I, for one, was profoundly disheartened and dismayed by the profound inequity around COVID access to COVID vaccines, therapeutics that played out globally. I think we thought we were farther along. And so I think, Mosapele, you lived through this firsthand. I don't know if you have any reflections on what major steps we globally need to take to do better as partners, in both with regard to access, as scientific collaborators and partners. What do we need to do to better? What are some action items for us?
Thank you very much, Shaheen. When we were dealing with this and getting stuck in terms of getting vaccine doses, I thought to myself, we have global rules around, for instance, financial transactions globally. And we gray list countries, we do all sorts of things. We have global rules around movement of people, migration, even the poorest country, people living and entering that country use passports, right? So, I asked myself the question, why don't we have global rules around things that will save all of us in the face of a pandemic? It's just baffling where our priorities are, that we can get it right to regulate movement of people or financial transactions globally, but we can't come together because even when we talk about, let's open a production site in Botswana or South Africa or Rwanda, well, when that outbreak happens, Rwanda is going to embargo the export of the product to save their people first if there are no rules that guide how collectively, after investing in whatever infrastructure to save the global population, the same thing is going to repeat itself in nations. So I think what is really, really missing is the relevant bodies coming together and say, what are going to be the global rules around investment on XYZ to help us address our global pandemics? And that will range from testing. I mean, when COVID broke out, I remember that there were nations, for instance, fortunately, places like Botswana wanted to and could buy testing platforms, but there was an embargo. We couldn't get them in. Certain instances we paid, but things didn't get delivered until there was oversupply in the nations where those manufacturing companies operated from. The same thing applied with vaccines. You will all remember that the countries that paid, but we never got the doses until there were some that were expiring because they couldn't move out of the storerooms in certain countries. So I think we need to have some kind of rules globally for how we would do this with the next pandemic. I think counting on the goodwill of a pharmaceutical company X or Y, I don't think it will get us far, because even when we come together, give an example with COVAX. COVAX had rules for how they were going to distribute vaccines. So in certain instances, the distribution model, when we costed our vaccine rollout plan in Botswana, if we had followed the COVAX path to procuring vaccines, we were going to have one of the most expensive vaccine rollout programs. Do you know why? Because they will deliver the first 2.3 million people, right? So if they said we'll give doses to cover the first 5% or 10%, it means we have to put up the infrastructure to vaccinate people. And then you have to wait for 3 months. Do you dismantle that infrastructure or you maintain it? In a sparsely populated country, where almost half live in small settlements of maybe 5,000-10,000 people. So when we looked at it, even if the vaccines that we're getting through COVAX were going to be reasonably priced, when you look at the cost of deployment, it makes sense for us to go through COVAX. So if you look in the Botswana vaccine procurement package, 50 to 60% of what we got was bilateral negotiations with pharmaceutical companies, because we need to vaccinate quickly to cut the costs of the rollout itself. So sometimes even when we think we're trying to achieve equitable access, we come up with something ridiculously expensive that the ones that you're trying to facilitate cannot ultimately even afford to give people the jabs at the end of the day.
Thank you. Thank you very much. Unfortunately, I know we're close to, we have maybe a couple more minutes. Okay, thank you so much. I wish we had more time. So I'm going to see, I wish we had lots more time, but maybe Linda Gale, we can start with you and have each of you maybe give a couple minutes, 1 to 2 minutes of remarks as you'd like to close this out. Thank you. You're on mute.
The famous mute button, sorry. Just, my reflections as I've been listening to this is that maybe the most important thing I would say is that we really learn from history, right? And apply forward. Because I think there have been extraordinary lessons in just the last 2 epidemics, particularly HIV and in the COVID. There are, of course, epidemics that continue. Tuberculosis continues to ravage on, and malaria and many others. So, what can we learn and what can we take forward? And I'm an eternal optimist, so I'm going to believe that we will learn from our mistakes. And what makes me, optimistic is seeing how, I already mentioned, how we saw longevity and life expectancy plummet, in the mid-2000s in this Eastern Southern African region. And now we start to see that again begin to increase. There's no doubt COVID has set that back to an extent, but the fact that we've been able to come out of this and move back gives me a great deal of hope that we can apply lessons and we can move forward. But what I would say, the most important lesson to take forward is that There is no part of our community that we can leave behind. And as Mosapeli was talking, I was reminded that the next ingredient we brought into COVID, and I believe the same happened in other countries in this region, was bringing the private sector in to the public sector. So it was really a multi-sectoral approach. And then, as Maureen has already so beautifully illustrated, civil society had to come along. Now, we faltered somewhat in COVID-19 in bringing civil society along, but we did course correct at some point. So I'm hopeful that by applying the lessons of the past and taking that forward, we can actually do better in the future. And that's what I'm going to hold on to. But the lesson that this cannot be done by one single part of the health environment is an important one, that it really is multi-sectoral and that we do need to bring all the players along in order to get the best results. Thanks, Shaheen.
Thank you for that lovely statement of unity and cohesion. I couldn't agree more. Maybe Mosapeli, would you like to share last reflections?
Thank you very much, Shaheen. I, like you, Linda, the ultimate optimist. I believe there's more good than bad out there. And I believe in the immense human capital that we have everywhere in the world. We just don't see it. So many smart, hardworking people that only maybe need us to just, remind them that they too are so important and can make a huge contribution to everything that we do. I think as a scientific community, we cannot live in a bubble where we don't realize the impact of misinformation and how some of the amazing discoveries we make or the science we publish is not impacting people. I think social media and sometimes politics interferes with the good that scientists have put together that can benefit so many people. So I think we ought to start to think outside the box and look, either we ourselves acquire new skills or look for partners who can truly help us to effectively share and influence so that all the things that all the other scientists have worked hard to achieve can have true impact at a global level. I think the advances in science are so amazing, but if you look at the impact, it's not as good as it should be. And so what are we going to do? And I think that's a big challenge for all of us.
Thank you very much, Mosapeli. And Maureen, you have the final word.
Yeah, I'll be super brief. I think it's quite reassuring, as I said earlier on, to see how community engagement is actually being recognized, community engagement leadership. I think we've moved from a point where committees were just recipients of programs and all that, but we are now actively participating, engaging communities in the delivery of services. We are increasingly seeing the adoption of peer-led models, community-led responses, I think, which is quite reassuring. But that's not enough. I think we need to make sure that we are investing in communities so that they can be able to implement, to be equal partners in the delivery of services, in the design, in the planning at all levels. And then, like I said earlier on, when you talk about community involvement, it has to be at all levels. It's not about picking and choose to say, oh, this is too technical for communities. They want understand. They do understand, right? We have communities at different levels. We have community members that are getting degrees at Harvard, at Oxford, that can understand that technical language. So I think for me, that gives me hope that there's that recognition, but it's not enough. We need to make sure that we are investing, we are creating that space and that community participation. It's not just tokenistic, but it's real. Yeah. Thank you.
Thank you so much. All right, thank you all.